All right, let's get started. Welcome to a presentation on the topic of home parenteral nutrition and bone health. My name is Vanessa Kumpf. I'm a clinical pharmacist specialist at Vanderbilt University Medical Center. Thank you all for attending. Sorry we cannot be together in person, but on the positive side, hopefully this is a good way to reach more people. Thanks to the Oley Foundation for organizing a fantastic program and for inviting me to attend. So let's get started. I have no conflicts to disclose. My learning objectives for the presentation are to define metabolic bone disease, identify risk factors, discuss strategies to maximize bone health when receiving parenteral nutrition, outline a plan to monitor and manage metabolic bone disease. So whenever I prepare a presentation, I like to first start by considering common misconceptions related to the topic. Here are statements that I consider to be myths. Number one, bad bones are associated with bone pain. This is not always true. Number two, bone health can be determined by routine lab monitoring. Don't be fooled by this. And number three, long-term parenteral nutrition is a risk factor for developing metabolic bone disease. You may have even heard this from a medical professional. So I will later provide evidence that discredits this statement. So let's talk about bone turnover. The skeleton is a highly dynamic organ. It's constantly changing and regenerating. The process is known as bone turnover or bone remodeling, and it is characterized by two activities. As illustrated on the left, older bone is periodically broken down or resorbed by osteoclasts. This is replaced by new bone made by osteoblasts, as illustrated on the right. This occurs throughout life, but the amount of bone mass typically reaches its peak by the third decade of life. As we age, we lose bone mass overall, but we're still always forming new bone. We'll later talk about medications to treat low bone mass that focus on one of these two activities. Metabolic bone disease refers to a spectrum of conditions that occurs when there is an imbalance between bone breakdown and bone formation. Metabolic bone disease encompasses osteoporosis, osteomalacia, or a mixture of both. Osteoporosis is characterized by low bone density, resulting in increased fracture risk. The diagnosis is based on bone densitometry, which we'll address later in this presentation. Osteomalacia is a disorder of bone mineralization and is characterized by softening of bone or decrease in bone strength. It generally occurs due to vitamin D deficiency, and the diagnosis is based on bone biopsy. The clinical presentation of metabolic bone disease is typically asymptomatic. There may be no symptoms. Osteoporosis may present with bone pain or even a fracture. Osteomalacia, again, also may present with bone pain, and typically this is at weight-bearing joints. Laboratory data may be normal or only slightly abnormal. So bottom line, don't be fooled into thinking that no bone pain and normal labs means your bones are perfectly healthy. Dual energy X-ray absorptiometry, which is abbreviated DEXA, is the machine used to measure bone density. It's considered the gold standard used for diagnosing osteoporosis. This is an illustration of what the machine looks like. It's a non-invasive X-ray, typically of your spine and hip area. It does not distinguish between osteoporosis and osteomalacia. As I previously mentioned, the diagnosis of osteomalacia requires a bone biopsy. And this is not commonly done because it's an invasive procedure and involves some risk. The World Health Organization provides criteria for the classification of osteoporosis using bone density measurements. It's outlined on this table. For those of you familiar with statistics, the scoring is based on a bell-shaped curve of population norms. The score represents the number of standard deviations from the norm. A T-score compares your bone density to a gender-matched, young, healthy adult population. A T-score of -1 means your bone density is 1 standard deviation below the norm. That's classified as osteopenia. Osteoporosis is defined as a bone density that is 2.5 standard deviations or more below the norm when compared to a young, healthy adult. ADEXA will also report Z-scores. A Z-score compares your bone density to a gender-matched, age-matched population. So you may ask, is home parenteral nutrition a risk factor for developing osteoporosis? You may have heard that it is. For those of you on HPN, should you be concerned? Let's look at the evidence. In a study looking at the prevalence of osteoporosis in adults receiving HPN, this is what they found. There were 164 consumers included in the study who had been receiving HPN for at least 6 months. A very high percent, 84%, were shown to have a T-score below -1, meaning osteopenia or osteoporosis. 41% were classified as osteoporosis. So these numbers are no doubt high. But a follow-up study with the same consumers who remained on HPN for another 1 to 2 years focused on the Z-score instead of the T-score. Remember, Z-scores compare your bone density to a population of the same age. In this case, Z-score remained the same at the hip and actually improved at the lumbar spine over time, despite being on HPN. The question then becomes, is HPN a risk factor, or is it really the underlying intestinal disorder that is the risk factor? It's an important distinction. One way to help answer the question is to separate patients out between those with intestinal insufficiency and those with intestinal failure. The difference between intestinal insufficiency and intestinal failure is the requirement for parenteral nutrition or IV support. Intestinal insufficiency is defined as the ability to maintain health by enteral nutritional strategies, where intestinal failure is defined as dependency on PN or IV support. So if we separate patients based on this category, we can evaluate if HPN influences risk of osteoporosis. If HPN itself is a risk factor, then you would expect to see a higher rate of osteoporosis in patients with intestinal failure compared to intestinal insufficiency. So this chart illustrates those results. For those with intestinal insufficiency, which is the bar on the middle left, 34% had osteopenia and 51% osteoporosis. For those with intestinal failure, the bar in the middle right, 30% had osteopenia and 61% had osteoporosis. So the numbers are high for both groups, but not statistically different from each other. So this suggests that the underlying intestinal disorder is the risk factor and not the HPN. So what are other risk factors? In addition to the underlying intestinal disorder, here's a list of risk factors: low BMI, vitamin deficiency, negative calcium balance, magnesium deficiency, aluminum toxicity, copper deficiency, chronic inflammation, corticosteroids, loop diuretics, prolonged bed rest, and smoking. So now let's talk more about the nutrient-related risk factors. First, let's talk about calcium. Most of us have heard that calcium plays an important role in maintaining bone health. In fact, 99% of calcium is stored in bone. So let's specifically focus on the influence of HPN on calcium balance. Unfortunately, we do see an increased loss of calcium in the urine of patients receiving HPN. And here's a list of those PN risk factors that promote the loss of calcium in the urine. Number 1 is high protein dose. A study that compared 2 to 1 gram per kilo per day found increased urinary calcium loss in those receiving the high protein dose. Another factor is the calcium dose itself. The higher the calcium dose in the PN, the more that is lost in the urine. What this means is that you can't just necessarily offset the calcium loss by putting more calcium in the bag. Other factors that promote calcium loss are inadequate phosphorus, higher sodium dose, chronic metabolic acidosis, and cyclic compared to continuous infusion. Based on these factors, there are ways we can modify the PN formula to minimize calcium loss. One thing we can do is avoid excessive protein. When clinically appropriate, we try to reduce or maintain a protein dose of about 1 gram per kilo per day. Another important strategy is to provide adequate but not excessive calcium intake. We're somewhat limited in the amount of calcium that can be added to the PN based on its compatibility with phosphorus. The recommendation is a calcium dose of 10 to 15 milliequivalents per day in the PN formula. Like calcium, we want to provide adequate but not excessive phosphorus intake. The recommendation is to provide a phosphorus dose of 20 to 40 millimoles in the PN. And there's also this optimal calcium to phosphorus ratio that we can use as a guide to optimize bone health. Another important strategy is to avoid metabolic acidosis. So metabolic acidosis can occur in patients with high stool output, and metabolic acidosis was on the list of things we talked about that can increase calcium loss in the urine. But the good news is that we can modify the acetate dose in the PN to avoid or treat metabolic acidosis. Next on the list is to avoid excessive sodium intake. And lastly, the rate of the PN infusion can influence calcium loss, where the faster the infusion, the greater the loss. So if you compare a given amount of calcium infused over 12 hours compared to 24 hours, you'll see more calcium lost in the urine with the 12-hour cycle. So you could consider lengthening the infusion time to minimize calcium loss, but in practice, it's not really very popular to do that. And the downside of that is that there can be more risk to the liver over the shorter infusion or the longer infusion time. So this overall probably isn't something that we do very often. An important method to optimize calcium balance is the use of oral calcium supplements. This even applies to those of you who may have malabsorption or those on HPN. The recommended daily allowance of elemental calcium is 1,000 to 1,200 milligrams, but for those of you with an intestinal disorder, you may be asked to aim even higher. Calcium citrate is typically better absorbed than calcium carbonate, but frankly, really either form is probably fine. I encourage you to read the label on the calcium supplements you're taking, know what you're taking, look at the dose per tablet, provide that information to your health professionals. Limit each dose to no more than 500 milligrams, so you'll want to space out the doses throughout the day. Avoid taking at the same time as any iron or magnesium supplement, since they can interact with each other and decrease absorption. The most common side effects with calcium supplements are constipation and indigestion. The next nutrient that's important for bone health is vitamin D. Vitamin D3 is synthesized in the epidermis of the skin. This requires ultraviolet B rays, and it is based on physiologic need. So we know that exposure to the sun is an effective way to maintain adequate vitamin D status. But the fact is, many of us limit our sun exposure for various reasons, myself included. As a result, vitamin D deficiency is really relatively common. There are vitamin D fortified foods available to help, but the reality is you really need very liberal consumption of these foods to meet requirements. We know that vitamin D deficiency occurs in well-nourished, healthy individuals due to avoidance of sunlight. So in fact, malabsorption of vitamin D from food really plays a minor role in development of vitamin D deficiency. Vitamin D status is based on serum 25-hydroxy vitamin D level, where insufficiency is defined as a level between 20 and 29, and deficiency is a level less than 20. It's well documented that vitamin D deficiency is common in patients with intestinal failure. And in this study of 106 adults with intestinal failure, 67% were deficient in vitamin D. Interestingly, there was no difference between those receiving PN to those not receiving PN. In fact, there really was no evidence that the severity of malabsorption influences vitamin D deficiency. This implies that it's really influenced more by sun exposure, not malabsorption from food. So knowing that vitamin D deficiency is common, what can we do to prevent and treat it? The adult multivitamin injection that's added to PN provides a standard vitamin D dose of 200 international units. This is often not enough to treat a deficiency, and it may not even be enough to prevent deficiency. In addition, there is no individual injectable form of vitamin D that can be added to the PN. So really what this leaves us with is the oral route as the best option. Long-term oral supplementation of vitamin D is often required to maintain adequate vitamin D status. The oral dose required really varies greatly. This is where the extent of malabsorption is a factor on the dose that is often required. For those with vitamin D insufficiency, so this is that level like between 20 and 30, an over-the-counter vitamin D supplement is oftentimes adequate. That's usually what we start with. For those with vitamin D deficiency, so a level less than 20, we typically start with a prescription strength vitamin D of 50,000 units once a week. And my little notation there on the bottom is just to inform you about a new FDA regulation. So you're going to start seeing more of the metric units on the label for vitamin D rather than international units. That's going away, and so you'll see things like milligrams or micrograms. Right now the label has both, but eventually you'll see international units go away. So don't let that confuse you. Aluminum is another risk factor. Certain ingredients that are added to PN can potentially be contaminated with aluminum. Aluminum contamination in PN has been associated with osteomalacia and osteoporosis. But these were older studies. The good news is that the old source of protein that was previously used has been replaced with crystalline amino acids. And this has significantly reduced aluminum contamination. In addition, the FDA now regulates aluminum content for components that are added to the PN. So the amount of aluminum content must be limited for large volume components such as dextrose and protein, and for small volume components such as electrolytes, the manufacturer is required to provide the maximum aluminum content at the time of expiration with the packaging. And then it's the responsibility of the pharmacy who compounds your PN to select products with the lowest aluminum contamination. There are some other nutrient deficiency states that can impair bone health. I have listed here, includes magnesium, vitamin C, and copper. Those with intestinal failure are particularly at risk of magnesium deficiency due to impaired absorption and increased output from stool output. So we really want to work on correcting any of these deficiencies. Let's next discuss the appropriate lab monitoring recommended to maximize bone health in patients with an intestinal disorder. We want to identify and correct lab abnormalities that may increase risk of developing metabolic bone disease. So this table outlines a lab monitoring strategy. It includes a comprehensive metabolic panel, magnesium and phosphorus levels every 1 to 3 months. A vitamin D is recommended every 3 months until stable, and then we can back off to every 6 to 12 months. And the other parameters listed here are maybe necessary on occasion, especially if you've got intervention that you're wanting to assess. So let's go back to the DEXA scan. We've talked about using it to diagnose osteopenia and osteoporosis. So when exactly should it be done? It's first recommended that it be performed at the onset of intestinal insufficiency or intestinal failure at the time of diagnosis. If the results are normal, it should be repeated every 2 to 3 years. If you're actively undergoing treatment, you may want to repeat it more often, like every 1 to 2 years, but this really is dictated more by insurance reimbursement. Keep in mind that the preference is to use the same scanner whenever possible. So what's the recommended management if you are diagnosed with osteopenia or osteoporosis? First, a thorough history and physical should be performed to identify risk factors. Management should focus on treatment of the underlying disease, any secondary causes, infections. We want to reduce chronic inflammation, minimize use of offending medications, and lastly, optimize the PN formula and oral nutrient supplements to minimize risk, which is basically what we've been talking about throughout this presentation. You want to optimize BMI. So for those who are underweight, we can use the PN as a way to promote weight gain. Lifestyle changes are important for promoting bone health. This includes stop smoking, engage in weight-bearing exercise, and reduce alcohol consumption. Fall prevention measures are important because people with a low bone density are at risk of increased risk of fractures. And finally, we recommend referral to an endocrinologist or a rheumatologist for those who are diagnosed with osteoporosis. If you remember the earlier slide that described bone turnover, the process involves 2 separate activities, the breakdown of old bone and formation of new bone. So this is a list of medications used to treat osteoporosis, and it's categorized based on where it works in this process. There are many available agents that decrease the breakdown of bone. Many are available as an intermittent infusion. There are also medications that work to stimulate new bone, formation of new bone. The choice of agent and duration of use really should be individualized. And it's a specialty area of practice, and that is why we refer patients to an endocrinologist or a rheumatologist for medication management. My final slide is a review of what I consider key takeaway points. Number 1, anyone with intestinal failure or intestinal insufficiency should be routinely monitored for metabolic bone disease. Number 2, PN is not a risk factor for metabolic bone disease. Number 3, the PN formula can be optimized to minimize loss of calcium in the urine. Read your PN label. Ask your provider if you have questions. Number 4, prevent and treat vitamin D deficiency with oral supplementation as needed and to take an oral calcium supplement. And number 5, for those with osteoporosis, consider seeing an endocrinologist or rheumatologist for medication management. And that concludes my presentation. Thank you all for attending. For those of you with questions, there will be a live Q&A session following the last speaker in this session, and I will also be hosting a breakout session this afternoon from 3:15 to 4:15. Goodbye.